Challenges with pediatrics is that there are some signs and symptoms that are incredibly non-specific. Jaundice in a neonate would be an example of this. The differential diagnosis of jaundice includes normal through to life-threatening hemolysis or sepsis. An example of this that is more applicable through all ages of pediatrics is vomiting. And I think it's useful to go back to how we might have a structured approach to a single symptom, such as vomiting, and have a structured approach to this, because you will unfortunately see lots of children who have vomiting as part of their presentation. The way I would try to think about this is, first of all, to establish that this is definitely vomiting. Now, vomiting is classically a situation in which the patient knows that something's going to happen. They start to feel nauseous. They might feel sweaty and tachycardic and have sympathetic overdrive. They then forcefully eject all the contents of their stomach, and they generally feel a bit better afterwards. And either that's the end of it, or it carries on and rebuilds up again. This is important because there'll be some things that might look like vomiting that aren't really vomiting. So, for instance, a child might be coughing a great deal, trigger a bit of a gag reflex and bring up some food. But actually, the primary problem is respiratory rather than gastrointestinal. There'll be children who are regurgitating. So we'll see small babies with reflux who are just effortlessly regurgitating. And in older children, we will sometimes see children with this effortless regurgitation syndromes. We'll see other children who've got an esophageal obstruction. We'll see esophageal atresia in small babies, and we'll see children who've got an esophageal obstruction, either because of a foreign body or something that's going on in the chest, and they're trying to swallow, but they just can't. Much more rarely we'll see structural abnormalities of the pharynx or the esophagus, or problems with food getting into the stomach. But the majority of the time we will get a classic history of a child vomiting. And the question is, what do we do with those? I would tend to think of it like this. There will sometimes just be children who vomit as part of their illness. They get a respiratory tract infection, and as part of that, they vomit. And that's part of the whole thing. There'll be other children who have got a primary gastrointestinal cause for their vomiting, and there'll be other children who have a primary neurological cause for their vomiting. When we think of gastrointestinal causes of vomiting, I suppose I would divide those up into children who's got some kind of inflammation of the gastrointestinal system. So they might have appendicitis or gastroenteritis, an infection somewhere in the gut that has got vomiting as part of that. And then I'll see children who vomit because of an obstructive cause. And that obstruction is either because there is an actual physical narrowing of that bit of the gut, and we'll see this particularly in neonates, in children who might have an intestinal atresia, all the way from esophageal atresia down to rectal anomalies. We'll also see children who've got a narrowing that's evolving, something like pyloric stenosis, which we might see in 4 or 5 week old babies, where the pyloric muscle narrows and they get this projectile vomiting of non-bile stain vomiting. They might have a narrowing lowers down this incomplete, something called a web, where there's a narrowing causing vomiting. There'll be other surgical anatomical causes of vomiting where there's a twist or a kink or a hernia. So you might have an incarcerated inguinal hernia. You might have something called intussusception, where the small bowel telescopes on itself. It's incredibly painful generally, and it causes obstruction. So you've got obstructive vomiting with green bile stain vomit. We'll see children with a condition called malrotation of volvulus, where the gut twists on itself. This can be very, very serious, presenting with bile stain vomiting at any age, but classically in small babies. And then we'll see children with what you might call a functional obstruction, because the nerves can't do peristalsis normally, either because there's no normal nerves there, something like Hirschsprung's disease, where there's no normal nerves, or the peristalsis just can't work normally because the child is sick. They've got severe sepsis, severe diabetic ketoacidosis, whatever it is that's causing their guts to not work normally. And so they just physically can't peristalse gastric contents through, and so they vomit. So to recap, I would think of any child can vomit if they're acutely unwell. I would then think about gut causes, and these are either going to be inflammatory or infective causes, or children with some kind of obstruction, either a surgical obstruction or atresia or pyloric stenosis, or some kind of twist and an interception and interception or malrotation of volvulus or a hernia, or some kind of functional nerve problem affecting peristalsis, Hirschsprung's disease, or something else causing the peristalsis to not be working well because the child is very unwell, hypokalemic, septic, diabetic, whatever. So those would be the sort of gut gastrointestinal causes of vomiting that we generally see, and they're very common. We'll also see children with neurological causes for vomiting, which is less common, but very important. You might vomit because of raised intracranial pressure. So anything causing pressure inside the brain will sometimes cause vomiting as part of that raised intracranial pressure. So if you have a child with vomiting who has a closed fontanelle or a bulging fontanelle that's still open, and you've got other neurological signs, or the child's lethargic, got reduced level of consciousness, or that child is life-threateningly sick with a bradycardia and hypertension, you've always got to think about raised intracranial pressure as a cause of vomiting. There'll be other children with neurological vomiting because something is making the vomiting center in the brain unhappy. And this might be drugs, it might be toxins, it might be complication of medication, or it might be accumulation of products, waste products in patients with renal failure or liver failure, or it might be children with very deranged calcium levels, salt levels, magnesium levels. All of these things you might vomit as part of that. Patients who are very ketotic with severe diabetic ketoacidosis, the thing that tends to tip them over is the point at which they become very ketotic and they can no longer keep fluids or salt or anything down, and they're just vomiting everything that goes into their stomach. So to recap, I want to use vomiting as a way of thinking about non-specific but potentially very important symptoms presenting in childhood, and how we have to have this very broad brush approach to taking the history and examining the child. As part of that, we have to think about the general health and well-being of the child. So a child with pyelonephritis, a kidney infection, might vomit, but generally it's going to be gut causes, either obstructive or inflammatory. Neurological causes, either raised intracranial pressure or something upsetting the vomiting center in the brain. We have to have a way of taking a history that remembers to think about red flags like green vomit, bile stain vomit, like other neurological concerns. We've got to have a way of taking a history that tries to put this together in terms of the age of the child, thinking about pyloric stenosis in a 1-month-old child, or malrotation and volvulus or intestinal atresia in a small baby. Thinking about the previous medical history, if this child's always been constipated, might they have Hirschsprung's disease? Thinking about a thorough examination of the child from top to toe and not forgetting the inguinal orifices, and making sure that we've really thought this child properly through, because that's going to tell us how quickly we need to get investigations, treatments on board, and who we need to refer to, whether we need to go down a surgical or medical route.